Iniciando as atividades do primeiro pré-congresso Sobep 2024, nós temos a grande honra de receber o Dr. Alessandro Villa, que ministrará o tópico intitulado Dry Mouth Diagnosis and Treatment in Elderly and Cancer Patients. O Dr. Villa é internacionalmente reconhecido pela sua expertise no campo de medicina oral e ele é atualmente o chefe dos serviços de medicina oral, oncologia oral e odontologia do prestigioso Baptist Miami Cancer Institute nos Estados Unidos. Seguimos então com a palestra digital do Dr. Villa.
As you know, dry mouth is a very common complaint that you may encounter in your practices and with your patients. And with today's presentation, I'm going to give you a general overview of the management options that are available for elderly patients or cancer patients affected by dry mouth. These are my financial disclosures for today's presentation. So before we dive before we talk about the different management options that we have available for the treatment of dry mouth and the different diagnostics that you may use in your clinical practice, I'd like to take a step back and briefly discuss the different function of saliva. This is a relatively busy slide, but it's to show you that saliva has really different functions that are really important to maintain a moist oral mucosa. And saliva is essential to lubricate the inside of the mouth. It provides the fluid that it's important to distribute taste in the oral cavity. It also acts as a buffer to protect the oral cavity, the pharyngeal area, and the esophageal mucosa from any ingested acid or acid regurgitation from the stomach. As you know, saliva also protects the teeth against the acid that then may cause demineralization of the teeth and therefore also dental caries. And saliva contains also many antibacterial, viral and antifungal agents that they can modulate the oral microbial flora in several different ways. And finally, as you can see here, it helps with speech, digestion in general, and saliva has also many functions which are needed for proper protection in general and functioning of the human body. Just to give you an example, saliva can also facilitate the healing of any oral wounds that may happen, for example, following a traumatic lesion in the oral cavity or a dental extraction. And when we look at the problem of dry mouth, we know that it's a very common and morbid condition. The data are really, when we look at the epidemiological data, as you can see here, we see a big range of the epidemiology and prevalence of dry mouth from 5% up to almost half of the population. And this is an issue that it's more common in the elderly. And we'll see that also cancer patients may be affected by these morbid complications. And there are different causes for dry mouth in patients affected by cancer. The definitions are really important because depending on the definition of dry mouth, there are different therapeutic options. And as you can see here, we can talk about xerostomia or true salivary gland dysfunction or hypofunction, dry mouth in general, and there are many, many other definitions. But for the purpose of today's presentation, I'd really like to focus on two. One is xerostomia, which is defined as the subjective feeling of oral dryness. This means that a patient may complain of dry mouth, and when we check the presence of saliva, they may have a normal salivary flow. And then there are patients with salivary gland dysfunction. This refers to changes in the quality and quantity of saliva, very common, for example, in patients affected by a complications of bone marrow transplantation called chronic graft-versus-host disease. Patients may present with salivary gland hypofunction, which is an objective decrease of the salivary output, either in humans or animals. And hyposalivation is instead defined as a decreased salivary output when we measure the salivary flow rate, and this is less than 0.1 milliliter per minute when we measure unstimulated saliva. Usually this is done by asking a patient to spit saliva in a container and then measure the weight over a specific period of time. And the stimulated saliva, patients usually are asked to chew on a piece of wax. There is mechanical stimulation of saliva, and we consider hyposalivation when patients have a stimulated salivary flow lower than 0.7 milliliters every minute. What it's interesting here is that the term dry mouth usually encompasses either xerostomia, so the subjective feeling of dryness, or salivary gland hypofunction, or a combination of the two. What are the main risk factors and contributing factors for the developing of dry mouth? Dehydration is one of the most common. Several patients don't drink enough water. Polypharmacy, so a number of drugs, and there are more than 200 drugs that have been reported in the literature that are responsible for the development of dry mouth. Sjogren disease, which is an autoimmune multi-organ syndrome, and I know Dr. Shibosky in one of the previous lectures has provided a very nice overview on Sjogren disease. For the purpose of today's presentation, I'm gonna only talk about Sjogren in the next few slides for a few minutes. Radiation therapy is the #1 cause of dry mouth in patients undergoing treatment for any head and neck cancers. More recently, we saw the role of new chemotherapeutic agents called immune checkpoint inhibitors. There are different types. Immunotherapy now is widely used for a range of cancers and has been associated with Sjogren syndrome-like symptoms with severe dryness of the mucosa. Anxiety also has been associated with an increased risk of dry mouth along with stress. And aging has been also shown to be an independent risk factor for the development of dry mouth. And finally, when we consider cancer patients, as I briefly mentioned just a few minutes ago, oral chronic graft-versus-host disease is a complication that can affect also the salivary gland, and these patients may complain also of dryness of the oral cavity. I'm an epidemiologist also. I like to give you an idea of the risk, and numbers always help understanding how morbid is a specific condition. There has been several papers published over the past 5 to 10 years that looked at all the studies on dry mouth, and one specifically looked at the number of medications that may increase the risk of dryness. And when a patient is receiving 2 or 3 of these medications, the risk of developing dry mouth is 2.5 higher compared to a patient that is not on these drugs. And usually the effect on the salivary flow of medications depend on the different drug interactions, how long the patient was receiving this medication for, and the dosage of the medication itself. A few years ago, back in 2017, there was a systematic review that included 46 medications associated with a dry mouth, and these included antihypertensive, antidepressants, sedative, antipsychotics, and antihistamines, which have been associated with the highest risk of dryness in patients. And a more recent meta-analysis looked at specific trials on amitriptyline, which is a tricyclic antidepressant, and patients on amitriptyline are at 11 times higher risk of having dry mouth compared to a patient that is not on this specific antidepressant. And also in older patients, older than 60 years of age, urological medication were found to have a very strong association of dry mouth. And why are these important? Because whenever we take a patient history and we go over the medications that the patients are on, we may be already able to identify those patients that are at higher risk of developing dryness, which we know is associated with not only a diminished quality of life, but also they're at higher risk of developing cavities and secondary infections. And specifically, a patient with dry mouth may also develop taste changes, functional deficits with difficulty swallowing or speaking, And a very good meta-analysis that included 6 cohort studies with almost 1,200 patients in total show that patients with dry mouth are at 11.5% higher risk of developing oral candidiasis, which is the most common fungal infection in the oral cavity, compared to patients that do not have dry mouth. So if we have a patient with a complaint of dry mouth, and going back to the definition, this is what we define as xerostomia, which is the subjective feeling of dryness. What can we do for our patients, and how do we approach a patient with a complaint of dryness? As we discussed, having a comprehensive dental, medical, and medication history is the first step. Patients should be examined both with an intraoral and extraoral thorough exam to assess any masses or asymmetry of the salivary glands. Some of these patients may also, if the patient presents with a mass, it's always suspicious for either a salivary gland stone or a possible cancer. And it's always important to measure the salivary flow at baseline. There are different methods that have been reported in the literature. Usually patients are assessed at a 5 minutes interval, and the most common outcome measure for assessing salivary gland hypofunction is usually the stimulated or unstimulated salivary flow. For patients with xerostomia, which is the subjective feeling of oral dryness, usually these patients, their symptoms are assessed through validated questionnaire that look at the ability of the patient with dryness to speak, swallow, or chew. And there are a long list of validated questionnaires, from short ones like the Fox questionnaire, which includes 4 questions, to the xerostomia questionnaire that has about 11 questions. And there's different tools depending on the time that you have with the patient that you can use to assess, again, the impact of xerostomia on the daily activities of our patients. I mentioned earlier that Sjogren disease is one of the main risk factors for dry mouth. This is a multi-system autoimmune disease characterized by infiltration of lymphocytes into the exocrine glands. It affects from 0.01 up to 3% of the general population, and it's more prevalent in women, although male can also be affected. These patients not only have dry mouth, they may have also other manifestations of disease, including inflammatory arthritis, pulmonary and neurological dysfunction, and also vasculitis. And it's important to note that these patients are also at a higher risk of developing non-Hodgkin lymphoma, which can present as a unilateral swelling of the salivary glands, but also other hematologic malignancies and solid tumors. When we look at the pathogenesis of Sjogren disease, it's complex and still not fully defined, but we know that some of the patients are susceptible from a genetic standpoint to develop this disease. There are infections that seem to play a role, along with hormonal factors. That is also maybe why we're seeing this disease more prevalent in women compared to men. And I'm not going to go into the details of the pathogenesis, but as you can see here, the pathogenesis involves also the inflammatory pathways, and there are specific antibodies that have been involved in the pathogenesis of Sjogren, which include SSA and SSB, which can be measured through a blood work. Sjogren disease really can affect the entire body, as you can see here, and usually 50% of patients complain of joint, GI, or skin involvement. 60% of patients may have pulmonary disease, and peripheral neuropathy is present in about 20% of the patients. Dry mouth is a common complaint, and these were data that were presented at the National Patient Conference for the Sjogren Foundation back in April of 2022. As you can see here, dry mouth was a symptom experienced by the majority of patients, along with dry eyes, 95 and 93% respectively. And as you can see here, patients may also complain of fatigue, joint pain, brain fog, all the other symptoms that we discussed just a few minutes ago. So we saw that dry mouth can be secondary to dehydration, certain medication, an autoimmune disease like Sjogren disease. But when we focus on cancer patients, I'd like to spend a little bit of time on immunotherapy, because immunotherapy is now widely used for a variety of cancers, from metastatic head and neck cancer to melanoma, and also some of the hematologic malignancies. And immune checkpoint inhibitors work by preventing cancer cell division through the suppression of different immune regulatory pathway like the PD-L1 or PD-1, to name a few. And they can be used either in combination with conventional chemotherapy or radiation therapy, or as monotherapy in to treat some of these cancers. Immunotherapy is associated with a variety of adverse events, including hypothyroidism, myocarditis, pneumonitis. These are some of the most severe, to rash, dermatitis, and oral lesions. And when we consider oral complications from immune checkpoint inhibitors, dry mouth is one of them. This is the work that we did in collaboration with some colleagues at Harvard. Dr. Yaming Zhu was one of my residents back then. He's now faculty at Tufts University in Boston. And he looked at about 4,600 patients who received immune checkpoint inhibitors for cancer therapy. And when we look at this patient, 6.8% developed some sort of oral complications, which included both dry mouth, oral mucosal diseases, and taste changes. And when we look at the dry mouth, you see here that this is the number one of the oral complications from immunotherapy, so highly prevalent. And as you can see from the graph here, these tend to develop during the first few weeks of treatment with immune checkpoint inhibitors. Brittany Klein at the Brigham in Boston also published this nice paper last year on the diagnosis and management of salivary immune-related adverse events from immune checkpoint inhibitor. Patients on immunotherapy may develop hyposalivation and xerostomia that is very similar to what we see with Sjogren disease. It's very important, the diagnostic workup in this patient, to understand what is the cause of the dryness to provide the best treatment. Some of these patients may benefit from lab work similar to what's been done for Sjogren disease patients, looking at ANA, SSB and SSA antibodies, and depending on the severity of xerostomia and the severity of salivary gland hypofunction, the treatment changes. So for patients that have a minor dryness, this can be managed with over-the-counter moisturizers. If the dryness is more severe, this patient should be treated also with sialogogues. There are two medications that work well for dryness. One is called cevimeline, which is usually prescribed at 30 milligrams 3 times a day as a starting point, or pilocarpine at 5 milligrams 3 times a day. Patients that cannot eat because of the dryness, that have really severe hyposalivation, in these cases, it's always important to discuss the patient with the treating oncologist. Some of these patients may require discontinuation of the immune checkpoint inhibitor. And because of these patients have dry mouth, all of them should be prescribed with prescription fluoridated toothpaste and instructed to maintain good oral hygiene because they are at a higher risk of developing dental caries. So when we look at a cancer patient, we talked about radiotherapy being one of the side effects, salivary gland graft-versus-host disease, and some of the cancer drugs like immunotherapy and other chemotherapeutic agents that can cause a diminished salivary flow in these patients. Salivary gland hypofunction in head and neck cancer patients is mostly secondary to radiation. Radiation over the doses of 25-30 grays usually has irreversible effects. Patients typically experience most of the decrease in salivary flow during the first week of radiation therapy, but we see that over the course of radiation, they may experience more and more dryness. There are some preventative strategies in preparation of these patients that aim to preserve the salivary gland function, especially the one of the parotid glands. Nowadays, the majority of patients are treated with intensity modulated radiation therapy, which is a more precise radiation technique, which has decreased also the prevalence and severity of dry mouth. There are some cytoprotective agents that can be administered prior to starting radiation therapy, like amifostin, although it does come with side effects and it's very costly. Patients may be instructed to use some of the over-the-counter moisturizers. There are some studies also that are still controversial looking at the role of submandibular gland transfer, where patients undergo a surgery prior to start radiation therapy to move the salivary glands, the major salivary glands, out of the field of radiation. And acupuncture also may have some good results in a group of patients undergoing radiation therapy. And then we have the systemic parasympathetic agents, like with muscarinic action that we discussed earlier, like cevimeline and pilocarpine. In terms of topical agents, there's a large variety of products in the market, from sugar-free lozenges, gums that are sugar-free, mucosal lubricants, and there's really a large variety of options available on the market, depending also in which country you're practicing. In terms of alternative therapies, low-level laser therapy with patients with low salivary flow due to chemo and radiation may have an effect. Acupuncture, we talked about this, still controversial. And there are also some new cutting-edge approaches with gene therapy as a potential strategy to prevent radiation-induced damage, and the use of adipose tissue-derived mesenchymal stem cells and adult salivary gland-derived stem cells. This is an area of research that could be a promising approach in the future for some of these patients. These are some of the classic signs that we see in patients with severe dryness. These are all patients that underwent radiation therapy for head and neck cancer. You see here depapillation of the tongue dorsum, the presence of dry secretion. These patients may complain of difficulty eating, swallowing. The taste also is not the same with food that tastes less or tastes different than what they were used to. And this is a patient that developed a secondary pseudomembranous candidiasis, which is the most common fungal infection. Coated tongue is also a complications of dry mouth. This is not a yeast infection. This is not candidiasis. It's really an overgrowth of the filiform papillae, usually either from dehydration or patients that are hospitalized and have a soft diet. The tongue can be gently brushed with a soft toothbrush or a tongue scraper no more than 10 times a day. And when patients go back to a normal solid diet or a good hydration, it tends to resolve completely. And these usually do not respond to antifungal therapy because they're not candidiasis. Another complications that can lead to dry mouth, and this is specific for cancer patients, is oral chronic graft-versus-host disease. This is the most common complication in patients receiving an allogeneic bone marrow transplant. It's clinically patients present with lesions that mimic lichen planus, like you can see here in these 4 different patients. You can see the classic lichen planus-like lesions with erythema, lichenoid lesions and reticulations, and the presence of ulcerations. Most of these patients respond well to topical treatment, although some of these cases may also require systemic therapy. And when the salivary glands are affected, these patients may also develop dry mouth. The clinical features are very similar to Sjogren's syndrome patients with difficulty eating, swallowing, pain, a feeling of oral dryness. And these patients are once again at higher risk of developing a recurrent fungal infection or dental caries, usually of the cervical margins or interproximal dental caries. And GVHD is a very common complication. It's present in 30 up to 70% of patients undergoing allogeneic hematopoietic stem cell transplantation. Salivary gland involvement is one of the most impactful of oral GVHD in a negative way when we consider the quality of life of patients. These patients often experience dry mouth even after conditioning regimens, so not only as a consequence of GVHD, and they may have both qualitative but also quantitative changes in salivary gland production, composition, and output in general. These patients with dry mouth, and these are two of my patients that underwent allogeneic bone marrow transplant, develop salivary gland GVHD and oral mucosal GVHD. The chronic type, you see here multiple mucocils. These are common findings. These are of the soft palatal mucosa. They can also be bothersome, and again, it's a sign that the glands are involved by the disease. These patients are also at a higher risk, as I said, of dental caries. This patient also had poor oral hygiene, but as a consequence of dry mouth in the context of salivary gland GVHD, the patient developed multiple cervical caries. And this is another example. This is a patient, you can see here the full mouth series of intraoral radiograph. That patient had very good dentition, then after the transplant developed really severe dryness, and this is unfortunately what happened. He also didn't have the best oral hygiene following the transplant because he developed some painful oral chronic mucosal GVHD, and unfortunately this is the bite wing that shows that develop multiple interproximal large cavities. Just wanted to spend a little bit of time on how to manage patient with salivary gland GVHD. This is a paper that was published a couple of years ago now, 3 years ago, on the use of prescription sialogogues for the management of xerostomia in chronic graft-versus-host disease patients. We included a total of 70 patients, the majority of which were on pilocarpine, and 13 were on cevimeline. And this was a retrospective chart review. We collected demographic data, what type of sialolog we're receiving for the management of dry mouth, and xerostomia scores and patient-related outcomes, reported outcomes. And as you can see from the graph here, most of the patients, again, were on pilocarpine, as I was saying earlier. And when we look at the percentage of improvement in symptoms from the baseline to the third follow-up, which was greater than 12 months, there is a significant improve in the patient-reported outcomes related to dry mouth in both patients receiving pilocarpine and cevimeline. And when we look at cancer patients, chemotherapy, beyond what we discussed earlier with the immune checkpoint inhibitors, can cause salivary gland dysfunction. And salivary gland dysfunction from chemo can vary from 10% up to 80% of the patients. And typically the symptom resolve after completion of chemotherapy. So compared to radiation therapy, where they tend to last for a longer period of time. Dryness, patients may complain of xerostomia beginning on the 7th or 10th day after the administration of chemotherapy. There are a variety of drugs that can impact the salivary gland function, including methotrexate, 5-FU, cyclophosphamide, to name a few. And some patients on anticholinergic medication for diarrhea or nausea may also experience secondary dry mouth. In terms of management, it's important to try to relieve the temporary symptoms, especially during the treatment while they're receiving the chemo. There are some strategies, including the use of salivary substitutes, mucosal lubricants, and some of the lifestyle modifications also in terms of diet. Patients may also use mechanical stimulations of the saliva with sugarless gums. 1% malic acid spray may also work to temporarily relieve some of the symptoms. And it's really a collaboration among the oral medicine specialists, the general dentist, and the oncology. I'd like to underline this point. These patients need to be managed together so that we can provide the best treatment options for them. Candidiasis is one of the complications from cancer therapy, especially in patients that develop salivary gland hypofunction. Candida albicans is the most common species detected in cancer patients, although there is a small percentage of patients that develop non-candida albicans non-albicans candida species in the oral cavity. The treatment we follow here in the United States, the guidelines of the infectious disease societies, patients may be treated with topical treatment with nystatin or clotrimazole troches. These medications are typically given to patients 4 to 5 times a day for 10 days at least, up to a couple of weeks. In some cases, they may require systemic therapy with fluconazole, which also helps with compliance because it's usually given as one tablet once a day for about 10 days. There are some options for refractory cases that includes voriconazole or posaconazole or itraconazole for those patients that don't respond to either fluconazole or the other topical treatment that we discussed today. And finally, cancer patients may also be affected by salivary gland dysfunction when they develop psychological disorders. Because of the cancer diagnosis, patients are at a higher risk of developing major depression, and depression in these patients may develop in up to 17-18% of patients. These patients may be prescribed tricyclic antidepressants or SSRI, which are all associated with hyposalivation. If you remember at the beginning of my presentation, I showed a meta-analysis that looked at amitriptyline, which is a tricyclic antidepressant, which is highly associated with development of dry mouth. And also, SNRI significantly increased the risk of dry mouth compared to an SSRI. So in general, what can we do for our patients? We talked about using topical mucosal lubricants and salivary substitute. There are other studies looking at vitamin E and antioxidant. Vitamin E and antioxidant should not be used due to the potential adverse event that they may have, the adverse impact that they may have on cancer-related outcomes, and a lack of it. There was no evidence of benefit of using this. There is another drug on top of pilocarpine and cevimeline called bethanocol, listed here, which may be offered during radiation therapy to reduce the risk of salivary gland hypofunction and xerostomia, although the quality of evidence for this was pretty low. And these are some of the products available out there. There's biotin, there are some dry mouth strips, Xylemel, that these are little troches that can be put on the gum of a patient at night and they slowly melt. There's Aquarol, which is an artificial salivary spray. I just put here a few, but there's really, like I said earlier, a laundry list of available products for our patients. Patients may also benefit from the use of chewing gum, always sugar-free, or some sugar-free lozenges, which can stimulate, at least temporarily, the salivary flow rate. But the best evidence really comes from the use of cevimeline and pilocarpine, which are prescription medications. There's still insufficient evidence to support the use of low-level laser therapy or acupuncture, amifostine, the surgery that we discussed earlier with the submandibular gland transfer, although there are some studies that support this, mesenchymal cells therapy, and there are studies that also looked at the use of ginger for the management of dry mouth with really controversial results as of today. I'd like to conclude by showing you this graph. This is a work that we have done a few years ago, and we looked at the benefits of involving dentists in the management of oral complications of cancer therapy in patients undergoing treatment for oropharyngeal cancer and oral cancer. And as you can see here, we compared patients with oral and oropharyngeal cancer that saw a dental provider compared to patients that didn't see a dentist. And when we look at these complications, patients that see a dentist usually experience less oral complications, including dry mouth, and this is also associated with a decreased cost for the patient and the healthcare system in general. And this once again underlines the importance of having a dental specialist involved in the management of patients with cancer as well. So this is our team here in Miami. We really have a large team to manage some of these patients with dryness. These are my contact information. If you have any questions, you can always email me or follow me on X. And thanks again for having me today.